Bueno, buenos días a todos. Para los que no me conocen, mi nombre es Daniela Gattini, soy gastroenteróloga pediátrica de Chile y actualmente me encuentro en Toronto, y junto con Veronica Busoni somos las coordinadoras del Working Group de Falla Intestinal del ABSCAN. Gracias, les
Necesito
agradecemos
que
a todos.
que me prendan la luz para el...
Creo que hay alguien que no está en mute. Bueno, les queríamos agradecer primero que todo su asistencia hoy. Sabemos que no es fácil a veces participar un día sábado en la mañana, pero creemos que este va a ser un webinar de un tema que es bastante específico, pero bastante fascinante, por lo menos para nosotros, y tenemos el honor de tener a la doctora Cecile Lambe de Francia con nosotros. Ahora les voy a dejar, bueno, para contarles un poco cómo va a funcionar hoy día en la reunión, porque estamos con 3 o 4 distintos idiomas. La doctora Lambe va a hacer su presentación, que está previamente, ella está acá con nosotros, pero ella previamente grabó su presentación, y finalmente vamos a dejar espacio para preguntas y para discusión. Si gustan pueden levantar la mano al final, o también pueden ir anotando sus preguntas en el chat, y Verónica y yo las compartiremos al final de la presentación. Así que gracias, y les dejo con Verónica, que va a presentar a la doctora Lambe.
Bueno, muy buenos días a todos. Mi nombre es Veronica Busoni, yo soy gastroenteróloga pediatra del Hospital Italiano de Buenos Aires. Y en esta ocasión, en primer lugar, quiero agradecerle a todos ustedes por haberse conectado un sábado a esta hora. Un poco la idea de este horario fue para que para Cecile fuera, digamos, algo más fácil de estar presente. Así que bueno, gracias a todos, y gracias también, sobre todo, a Cecile por conectarse hoy. Hoy entonces tenemos el placer de presentarla. Ella es Cecile Lambe, es una gastroenteróloga pediatra especializada en falla intestinal pediátrica y nutrición. Pertenece al servicio de gastroenterología pediátrica del Hospital Necker Enfants Malades en París. Es docente de la Universidad de la Ciudad de París, y en 2013 ella se hizo cargo del Centro de Rehabilitación en Falla Intestinal, ocupándose de los niños con nutrición parenteral domiciliaria. Es miembro de, de ESPGAN y preside el grupo de falla intestinal Ernica. Hoy nos va a hablar de falla intestinal en niños, diagnóstico y genética. Una charla que escuchamos en el congreso de ESPGAN, que fue excelente, y por eso queríamos tener la oportunidad de compartirla con todos ustedes. Así que, thank you so much, Cecile, for being with us today. The floor is all yours.
Thank you for giving me the opportunity to talk about diagnosis and genetics in intestinal failure in children. You know that failure is mainly due to short bowel syndrome, for about 50%, which varies whether you include Hirschsprung's disease in short bowel syndrome or in motility disorders. Intestinal obstruction represents about 15% of cases of intestinal failure and doesn't really vary along the years. Long segment Hirschsprung's disease about 10%, non-primary digestive disease about 5 to 10%, and congenital enteropathy, which is the group of disease where there has been the most advances in genetics, is about 20% of our cohorts. It's only 20%, but it's where we have improved the most in genetics, probably because of the monogenic nature of this disease, and because they were very often in consanguineous families with a recessive mode of transmission. So the diagnosis is firstly clinical. You need to record the prenatal history, the age at onset of first symptoms, which is critical as a key factor in the diagnosis, whether they are extraintestinal manifestations, where the diet has changed the symptoms, the full family history, obviously with evidence of consanguinity in the ethnicity. The serum testing will help to know whether there's inflammation, whether there's lipid anomaly, or protein losing enteropathy. The stool output is extremely important to monitor, and you need to be careful because Watery stools can be mistaken for urine. And what is probably the most important test to perform is a no-feeding trial of at least 24 hours with the assessment of the stool output during that time, because this will actually guide you towards the three groups, three mechanisms of these early onset severe diarrhea. Because if the diarrhea disappears at bowel rest, it's probably due to the diet. So you then just need to adapt the diet and do testing. If it reduces at bowel rest, you need to go back to the family history and the pregnancy history and look for protein-losing enteropathy. If it persists at bowel rest, you need to look for consanguinity, where there is facial dysmorphy, and also family history, and where it's very abundant watery diarrhea. Once you've done all this, it's time to go to intestinal biopsies, but you already have a very good idea, a very good picture of what's happening. So, of course, pathology was probably the biggest help we had not that long ago to try to define those diseases and to understand the mechanisms. What are defects of digestion, absorption, and transport of nutrients? It can be defects of enterocytes, differentiation, proliferation, and position. It can be also defects of enteroendocrine cells and not so much enterocytes, and another group of disease which is everything to do with inflammation and the modulation of the intestinal immune response. So once we know this, we could look for what was behind those diseases. The first disease of interest is the most severe cause of congenital enteropathy. It's Necrovilus inclusion disease, which causes anhydrinus during pregnancy. There's an immediate onset of diarrhea at birth with usually 20% dehydration, a loss of weight due to dehydration, so extremely severe diarrhea, most times mistaken for urine. At the pathology with abnormal brush border, abnormal PA staining, and intracytoplasmic secretory granule, which gave a name to the disease. It's the most severe and the most permanent intestinal failure cause, with sometimes children not able to go off PN for just a few hours. It was also the first that was identified in 2008. So this disease is caused by MYO5B loss of function mutations. It's a very long gene, so very long to sequencate, but it was the first advent that was made, and children with clinical Necrovilus inclusion disease seem to have MYO5B loss of function mutations. The second disease of interest was tufting enteropathy, which is a very characteristic pathology. Sometimes extra-intestinal manifestations. And the first gene that was identified was EpCAM, which is an adhesion molecule, and is involved in the adhesion, the migration, the proliferation, and the cell differentiation of enterocytes. And that was very consistent with the finding of tuft on the biopsy. But what was a bit confronting in that some children with characteristic tufting enteropathy on clinical signs and on the biopsy didn't have any EpCAM mutation, and these children usually had extra-intestinal manifestations. So secondarily was found another gene, which was PIN2, and what's interesting is that it actually interfered with EpCAM pathways, so it all made sense, but probably with more implication in other organs. And that was in 2014. So you see here the mechanisms of a congenital tufting enteropathy, and probably what we thought was the cause of the disease, this disorganization, this tuft, this disorganization of the villus is probably more a consequence, not the cause of the disease. The cause is an abnormal polarity of the cell and this absence of adhesion. The third disease of interest was the Trichoid Enteric syndrome, again happening mainly in consanguineous family, with very characteristic small for gestational age baby. When I say small, it's really small, usually 1 kilo, 1.5 kilo for term infants, associated with an immune deficiency and with characteristic hair anomalies, which are known as trichorexis nodosum, sometimes liver disease. The first gene that was found was mutation in TTC37. It was in 2010, and the second gene that also helped to understand the mechanism of the disease was mutation in SCIF2L. And same, they are proteins that are play a role in the regulation of RNA, which explains the extraintestinal symptoms. Advances were made in Necrovilus inclusion disease too, because not all the children with Necrovilus disease had MYO5B mutation. So recently, other genes were identified, such as syntaxin 3, and most recently, UNC45A, which causes Necrovilus inclusion disease by impairing MYO5B apical trafficking. So all these proteins actually interfere with each other. UNC45A is a co-chaperone of MYO5B, but if you don't find the gene, you won't find the mechanism. And last disease I would like to talk to you about is DGAT1 deficiency, which is interesting because it's really when intestinal failure meets nutrition. These children have intestinal failure, they don't grow, they need parenteral nutrition, they don't have very severe diarrhea, and with time and with specific diet, they get better, probably because of the mechanism of the disease. So when you look at the clinical approach of congenital diarrhea, you can, from your clinical approach, have a clear picture of the genetics, especially if you have performed a bowel rest and no feed trial. But it's obvious that genetics is helping us, and it's quite tempting to, instead of doing all this, to just perform a next generation sequencing panel with all this, and you don't have to think, and the result is in 2 weeks, and there you go. But if you don't do this, you will lose your clinical skills. And yeah, genetics is helpful, but it's only to confirm what you have found and to maybe help to understand the mechanisms to find new treatments. Now let's talk about another severe disease, which is chronic intestinal pseudo-obstruction, which is about 15% of intestinal failure indications. It is very rare. It is characterized by obstruction without any lesion occluding the gut. It's mainly sporadic case, and it's more common in females. In pediatrics, most of the patients show symptoms in the first 12 months. And we can actually make a difference with these patients and the other on the mechanism. The early chronic intestinal pseudo-obstruction are mainly due to myopathy or neuropathy, congenital disease, principally due to megacystis macrocolon hypoperistalsis syndrome, known as MMIHS, which is easier to pronounce, and the later form of site obstruction are mainly due to mitochondrial disease. I'm only going to talk here of primary pediatric chronic intestinal pseudo-obstruction. So you know that the nervous enteric system is very complex. It needs a precise coordination between the autonomic nervous system, the enteric nervous system, and the smooth muscle cells. So anything affected will cause dysmotility and obstruction. So how do you make the diagnosis? It's a obviously clinical signs confirmed with X-ray and contrast series. Esophageal manometry can be help if it's normal. Maybe that isn't chronic intestinal tube obstruction. You might look for other causes. You can proceed to transmural biopsy, but they are not always necessary, especially if you have already signs of mitochondrial disease, and surgery sometimes is necessary. The biopsies are not always helpful. They might be completely normal with extremely severe symptoms, but they might guide you towards a myopathy or neuropathy mechanisms. One of the first genes that was identified and that has that is causing the most severe form, one of the most severe forms of side obstruction in children is the Actin G2 gene that was identified in 2014 and causes about 40% of megacystis microcolon with SIPO with megacystis. Other genes have been identified, but they're less common. What is particular is that ACTG2 is a dominant transmission. Most of the cases are sporadic. So there are quite a few genes that have been identified, and you can differentiate between early SIPO, which will be mainly due to ACTG2, which is autosomal dominant, and autosomal recessive, which are mainly going to cause mitochondrial disease. There's also X-linked heredity with filamin A gene, for instance. So this has clinical implication because the management is going to be different according to the genetics. If it's mitochondrial disease, you don't necessarily need to do surgery, whereas if it is ACTG2, it obviously needs all these procedures. And again, you're not going to offer intestinal transplantation in case of mitochondrial cytopathy because there will be neurologic symptoms that will appear, so it doesn't make much sense. One other cause for intestinal failure, which extensive genetics, is Hirschsprung's disease. So just to remind you of the history, it's one of the most known gastrointestinal disease. It was first described in 1886. It's due to the absence of enteric ganglia in the distal intestine, and it is a sort of intestinal tube obstruction. It was one of the first diseases where there were identification of mutations in the proto-oncogene rate in familial Hirschsprung in 1994. So Hirschsprung's disease, so there isn't one Hirschsprung's disease, as you know. It's pretty common, but long segment Hirschsprung disease, which is of interest for us, is only 20% of case, and you can see only 1% of case go to total intestinal ganglionosis. There's a male for female ratio, and they are familial form, usually with a multifactorial inheritance pattern, and sporadic form are the most known. And they can be associated with chromosomal aberration or congenital malformation. So the diagnosis is made usually in the first month of life with neonatal obstruction and delayed passage of meconium. The X-ray can be misleading in case of very long segment Hirschsprung's disease. And the contrast series will help you to see the length of a ganglionic segment, and manometry will help for the diagnosis, and the diagnosis really is made on the biopsy with hypertrophic nerve fibers and the absence of ganglionic cells. To understand genetics, you need to know the pathophysiology. It is complex because it is due to, the genetic is complex because the mechanism is complex. It is due to lack of craniocaudal migration, differentiation and maturation of neuroblasts from the neurocrest. And anything that will happen, any gene that will express or not express properly in this process might cause the disease. So there are several genes that are implicated in this development. So it is important altogether for the treatment and for the genetic counseling. What has been identified so far is that RET proton congen is the gene the most responsible of familial cases. You can find RET mutation in about 50% of familial cases of Hirschsprung's disease and in 20% of cases sporadic. And then comes endothelin RB genes and endothelin 3, but you see are much less common, and then all the other genes that have been identified are very rare. And you can see here an illustration of how complex this genetic is, with coding variant in some genes which are going to have a large effect and common variant with small effect. Very rare, so it's very difficult to predict. It's very difficult to predict the extent of the disease, whether it's going to be TIA, TCA, short Hirschsprung's. There's still a lot of research to do. Finally, I told you that short bowel syndrome was the leading cause of intestinal failure, but it's in this group of disease that we have the less insights on genetics. And the only insights we have in congenital short bowel syndrome, which is usually associated to malrotation and sometimes dysmotility, where a few genes have been identified, such as CLMP, FOXF1 most recently, and filamin A mutation, which is a frontier entity with short bowel syndrome and pseudo-obstruction. And in this form, the short bowel actually appears to be protective for the dysmotility symptom. There are some cases of familial atresia, like for instance familial apple peel syndrome. We haven't found the genes yet, but you see here that there is 2 siblings affected, suggesting an autosomal recessive mode in inheritance. In this family, yet another mode of inheritance, because father and daughter are affected. Same disease, both had to be on parenteral nutrition, both operated by the same surgeon. We still haven't found the genes. And for the other cause of SBS, I must say we haven't done any improvement. We know that gastroschisis happens usually in babies with young mothers. Toxic have been involved maybe, but what about predisposing genetic factors? Same with malrotation and mid-gut vulvulus. There must be something happening in the fetal development, but what are the genes? Same for intestinal atresia, it's sometimes associated with other disease. There's a particular case of TTC7A, which is of recessive transmission, but it doesn't really cause short bowel syndrome. And again, necrotizing enterocolitis, what are the predisposing factors? So in conclusion, you have to keep in mind that intestinal failure is mainly caused by short bowel syndrome, but I would say that we don't know much about the genetic of short bowel syndrome, but as every path leads to Rome, every disease seems to lead more or less to short bowel syndrome, because you can, in case of pseudo-obstruction, you have filamin A and CLMP mutation that are short bowel syndrome. You can have to proceed to enterectomy with very severe form or SIPO, and then you have short bowel syndrome. Same with long segment Hirschsprung's disease in case of total intestinal ganglionosis. In case of necrotizing enterocolitis, enterectomy, you will have short bowel syndrome. And again, congenital enteropathy, you might have to proceed to enterectomy in very severe form of diarrhea. You might have done intestinal transplantation and have graft removal, causing short bowel syndrome, and you might have those frontier entities such as TTC7A that cause short bowel syndrome. So there isn't one solution. It would be very interesting to have an intestinal failure genetic panel. for us, which look after intestinal failure patients, might be the future, but there again, genetic advance lead to the understanding of the mechanisms and lead probably to potential treatments, but we still need to keep our diagnosis on those clinical signs to think, and genetic testing should not replace our thinking. But I'm afraid that artificial intelligence, genetics, will be quicker than us very soon. Thank you for your attention.
Thank you very much, Dr. Lambe. That was a great talk. I was able to hear better. I hope most of our audience was also able to hear well. We want to open now the floor for questions. Un recordatorio para todos los que ingresaron a la reunión después de la introducción. Si gustan pueden escribir sus preguntas en inglés, portugués o español en el chat, o en francés también para la doctora, y nosotros también podemos traducir en caso de necesidad. No sé
Hi,
si
everyone. Good morning. Can I ask a question?
Yes, Natasha.
Hi, I'm Natasha. I'm a physician practicing in Brazil. I know Daniela from my old days, not so old, a year ago, the fellowship at Trichoid. Thank you so much, Dr. Cecile, for your presentation. It was a very comprehensive review on the genetics of intestinal failure. I wonder if during your review, you found that any of these generic variants that you comment on, or specifically one of them, were evaluated consistently with any genetic scores for pathogenicity, and if there is any sort of genotype-phenotype correlation for these specific diseases, because I have worked in the past with Actin G2, and we could not find anything consistent in terms of genotype and phenotype correlations. Did you find anything for other types of dysmotility or congenital diarrheas?
Yes, thank you for your question. We are more advanced in congenital enteropathy, I was telling you, because we've got the most experience, especially in our lab. And we're getting to the point where we are seeing, maybe, not completely sure, but a bit of genetic phenotype correlation, because, for instance, some children have a much more favorable evolution. For instance, you can see that after a few years, you can wean them from parenteral nutrition. And we're looking at the mutation, and they all seem to be like splice mutation and not stop codon, for instance. So you imagine that the protein is just a little bit changed, but not completely absent. And so I think now that's the next step, is just to go into that segment for research and try to be a bit more accurate in not only diagnosing, but predicting the evolution. I think there's certainly some clue that lead us to go into that field.
Thank you so much. Can I just make a comment on that? I thought it was very interesting how you presented about the MYO5B mutation. And we have this perception that it's an awful disease, an awful type of congenital diarrhea. I think you mentioned as perhaps one of the most severe forms of congenital diarrhea. And I work with hepatology now, and now we are diagnosing these children with only cholestatic liver disease, right? Normal GGT-P fix. And we see that they have either minimal or no diarrhea at all. Could you comment on that as well?
Yeah, no, it's just fascinating. It is fascinating. For instance, we have the example of this child that is now 20 years old, and he didn't have a diagnosis. He was on parenteral nutrition. All the doctors thought he had IBD, so he had azathioprine, he had steroids, and in fact, after 12, 15 years, he went through the chip with congenital enteropathy, immune disease, and it's MYO5B that came out, which is completely surprising because he was only on 4 nights a week of parenteral nutrition, So yeah, I think there's a lot of surprise that that's what the new technology is offering us, and I think that's great.
Great, thank you so much.
Sorry, there's a paper now in 2021 that they described 3 types of compromise in Myo 5B. According to the type of mutation, you can have like a predominant or only intestinal compromise, or a liver disease, or a mixed compromise. Taking into account that the small bowel, that after small bowel transplant in a patient with Necrovilus inclusion disease, they can develop a liver disease, which is the role of the analysis of the type of Myo 5B mutation to decide the inclusion of the liver in the small bowel transplant.
Well, it's a very good question. I don't think we're this far in our research. It'd be very interesting to go further, especially as you said, we don't really know who is going to develop a liver disease. And we have seen children who didn't have any liver symptoms just because they didn't reabsorb a biliary salt and became extremely sick after transplantation, to the point where you just have to think of a liver transplantation afterwards. Although the liver is holding on, but it's mainly the symptoms of cholestasis with terrible itchiness. And so, yeah, to be very honest, we're not at that point yet of research, but I need to ask my colleagues to get into it. It's very interesting.
Yes, because I read the paper of 2014, and in your experience, around 28 patients with Necrovilus inclusion disease, there were 3 patients that after transplantation, after small bowel transplantation, they developed the liver disease that was not there before. So we have one patient that he's on the list, but his liver is okay, but we are afraid of transplanting him with only the small bowel.
Yeah, but interestingly, one of the girl who then had a graft removed, the intestinal graft removed, her liver was completely fine after that. So now she's 18 years old. She had 5 years of intestinal transplant, but now her liver is perfect, no problem. So it's really the fact that the salts are reabsorbed, and when they're not reabsorbed, it doesn't cause trouble. So it's quite interesting, really, the physiology. But it would be interesting to see whether there are correlation between the mutation. But we would have to pull all the patients together, because we've got so little cohort. I mean, in our cohort, maybe we have at the moment maybe 10 patients with Myo 5B mutations. So it's not much at all. So we'd have to go through all the centers and see whether we can conclude anything. I think that's where we need to put resources together.
Yes, you're right.
Yeah. I just wanted to comment that I think it's fascinating how a mutation, that once was considered pretty much an indication for intestinal transplant, we're starting to understand that it has a very wide phenotype presentation. We also have a very few patients with myosin 5B microvillus inclusion disease in Toronto, but we do see some spectrum of severity with a patient that presented with an extremely severe presentation that we ended up doing an enterectomy. That's actually one of the questions that I have for you. And then we also have a patient that presented with a very milder phenotype and ended up being positive for myosin 5B. But I think the question that I had for you is, I know in France, you have more experience than I think anywhere in the world with doing enterectomies in patients with microvillus inclusion disease. So in a way, you are a patient that has intestinal failure due to a congenital diarrhea. You are creating a short bowel syndrome. So I know it's something very novel that was started with you, and because we had a patient that was refractory, that required had very difficult hydroelectrolytic and fluid management, and put up over 200 mLs per kilo, we ended up deciding to go for an enterectomy, and the patient's actually doing better now. And we have not had to list her for transplant. So I just wanted your comments on that, because I know you have more experience with patients with enterectomy post myosin 5B, knowing that, you know, as intestinal failure doctors, it's hard to, you know, remove bowel from somebody that has bowel just because their bowel is not functioning well.
Yeah, we have a bit of experience, but the experience came mainly because of failure of intestinal transplantation. So, for instance, these children were undergoing intestinal transplantation, and because there were rejection, we had to take the graft off. So then we had these children that were before with their full intestine on the 24 hours PN, without being able to do cyclic PN. And after transplantation, they were okay, maybe for 2 years. And then you took the graft away. So you would have thought, yeah, they have very short bowel syndrome, it's going to be terrible and blah, blah. But in fact, they were actually much better without their intestine and without their graft than before transplantation. So that was quite interesting. So then we had the experience to proceed to enterectomy with a child just like you, but not only was on 24 hours PN, but was impossible to treat. If you like, she had to be hospitalized because the electrolyte balance was all over the place. She was dehydrating, although on PN constantly. So then we made the decision, that was difficult, to proceed to enterectomy, which was not complete, but she now is much better. She can be off PN for 10 hours a day. She doesn't need to be admitted to hospital anymore. So yeah, it made a big difference. So, but what we were uneasy about is that we didn't have a MYO5B mutation at the time. And it's only a few years later that we had the confirmation it was a Necrovilus inclusion disease, because it's UNC45A that came out. So there again, you know, there's a part of risk to take based on your clinical, what you see clinically in those children, and trying to make the best decision. So obviously it's a bit easier when you have the genetics, because you know that you can be based more on experience and science than just guessing what's going to happen.
Great, thank you. There's there's two questions in the chat. One is about if there's any experience, if you have any experience with patients with deficit of DGAT1.
Experience with what? What? Sorry.
With congenital diarrhea due to deficit of DGAT1.
Oh, yeah, we do more and more, because we completely ignored this disease before the gene was discovered just a few years ago. And now, because we included it in our NGS chip, we find it more and more often. And sometimes in children who don't have very severe symptoms, you just can't get them off parenteral nutrition, and you don't really know why. They just vomit or they have a bit of diarrhea. And then you found out DGAT1, and most of them will evolve quite well just in a few months or years, and you can wean them off PN. But you have to be careful, because they might have essential fatty acid deficiency. So they need to be monitored very carefully, these children. But it seems to be much more common than what we thought. And maybe we misdiagnosed quite a few patients a few years back.
Cecile, we have an experience with one child with DGAT1, and this child was beginning on TPN because it was really a failure to thrive. But as we could arrange the diet as being oriented, this child is now completely well without TPN, and it surprised us how good the child is going on.
Yeah, but the thing is that if you hadn't made the diagnosis, you could have thought it's an infant anorexia, it's a feeding disorder, it's a child that vomits. So I think it is probably a lot of children that have needed a bit of parenteral nutrition for a few months were in fact DGAT1 children. So, you know, those children, you don't really know what they have. You don't really understand why they need to be on PN, but they do need to be on PN. And I think we might have missed quite a few diagnoses a few years ago.
I have a question regarding the pseudo-obstruction patients. Because we know that this patient, we don't expect adaptation. It's going to be full life TPN. So we usually think that maybe it could be a good patient for transplantation, but there is a recent paper that showed that this group of patients have worse prognosis after transplantation. Their survival is much less. What's your think about this?
Well, I think that's where it's interesting to see what the genetic is, because did they have, you know, a genetic diagnosis? Maybe they have mitochondrial disease. You know, that's I think it's this group of patients where we need to work a bit more. We have concentrated on in the care on the congenital enteropathy because probably it was the easier. But I think there is a lot more work to be done on these patients and to understand why is the prognosis not as good as in the other intestinal failure cause, you see. I think there must be a reason. What's the reason? We need to find it.
Mm-hmm.
There's another question in the chat from Mexico, and Dr. Sergio Pachelo Sotelo. He asks if there is like a system of collaboration, maybe to perform this type of tests, because in Latin America, it's very difficult for us to ask for this type of test and to have them performed, to pay for those tests. So in your hospital, do you have like a system to collaborate with this type of patients and maybe perform this test for the people, the children in Latin America?
Yeah, we probably can do that, but then it's always a question of fundings, you know, that all these exams do have a cost. It's a lot less expensive than what it used to be. But yeah, if collaboration could be done, it would be great. But it isn't that hard. In fact, once you have the technique, it can be set up. Maybe there should be somewhere in Latin America where you could set this up.
Yes, maybe if you are trying to make like a larger group of for example, Myo 5B, maybe with our patients we can collaborate with the number and have the test performed.
Yeah. Do you have many congenital enteropathy in Latin America?
Yes, I in our hospital we have many, and it's not so. It's a very rare disease, but nowadays we have quite.
Yeah. So if we just pulled everybody together, it would be great.
Mm-hmm. Yes, nowadays in Argentina it's like easier, but it's not so. It's easier because in the past we had to contact you and send the sample to Europe or to United States. But nowadays it's like a little bit easier, but many times the insurance don't want to pay. So the patients, sometimes they pay for the test. And there are many places or many countries that maybe cannot do this type of tests, and it's a problem. But it's for me, it's very.
In Brazil.
Yes.
In Brazil, an exoma is around $1,000.
Mm-hmm.
Yeah, it's about the same in France, but what we do is we do the next generation sequencing chip. So that's a lot would be a lot cheaper, but can only test the genes that are on the panel,
Yes.
on the chip. So that means you wouldn't be able to find a gene that hasn't been described before.
Yes, as you said, for me, it's very interesting to study this type of patients and to think about which is the cause, and then ask for the panel and have the answer.
Surprise, yeah, I know.
We don't have the tests. We work like that, and then the genetic test just like affirms what we were thinking.
Yeah, sometimes we're wrong.
No.
Yeah. What is frustrated?
We say, what is this?
What's frustrated is sometimes we have a patient that we know there is a genetic disease that is involved with the symptoms, and we do the tests, the exoma, and we couldn't find anything. So this is so bad, because I'm that's the problem that I'm having just now with a child, which I'm sure the child has a genetic disease involved with intestinal, with important failure to thrive and the diarrhea, chronic diarrhea, but we couldn't find the diagnosis, and the exoma was totally normal, no mutation that could explain. So this is very frustrating, because we invest and we don't have the results sometimes. So
Yeah,
that's the point, that what kind of if we are looking at a child with chronic diarrhea, with failure to thrive, that there's no short bowel, but we cannot find the exactly diagnosis. Do you have a specific kind of mutations that should be looked for, or like to do, how to say, I don't know, to have a group of mutations that should be tested? What do you do?
Yeah, that's what we do. That's what we call the panel of a chip, if you like. So that's when we're testing randomly all those genes that can give diarrhea, or pseudo obstruction, actually, because we put everything together. But I think if we can't find anything on what's known, that's when we need to go further and go into exome or genome, especially if there is consanguinity in the family, because you're going to find something in 95% of cases if it's consanguinity in the family. So you really need to find the gene, and that's when you can really make new discovery, new genes, and then, like, you know, at UNC 45A, which is like MAO5B, and it's actually working with MAO5B, which is quite interesting. So in fact, when you've defined the type of disease that you're looking for, it makes it easier, and that's when you're going to find new genes. And you really need to go further. You need to go and see the geneticians and say, you know, there is something here, we need to find it, you need to find it. And then now with the new techniques, you just find it. Everything is quicker, everything is easier now. What used to take 3 years takes 6 months. What used to cost $10,000 cost $1,000. So now everything seems to be possible. When you see the improvement in just 10 years, it's just amazing.
I just wanted to echo something you said that I think it's very important for all of our colleagues, that the clinical suspicion of a genetic disorder is so important, because many times when you send a whole exome sequencing, and it happens to us many times here in Toronto, that, you know, we have patients that have SIBO or they have congenital diarrheas and they have a whole exome sequencing with no diagnosis, but nobody actually, when you do a whole exome sequencing, if you don't go directly and look at the genes for congenital diarrhea or for SIBO, you might not find something. So it's happened to us that we have patients that come to us for a second opinion that have a whole exome sequencing, and for example, they haven't done basic genes for SIBO that we look directly we asked our genetic team to look at it, and they find that the patient's positive for that. So that's why, these chips are really useful. We have a congenital diarrhea chip, but we're working on a SIPO panel as well. Right now, we were sending a lot of our patients to, we're doing the Seattle panel that has 12 genes for SIPO. And we are currently working on a Canadian one that has slightly more genes, but and we're also finding that some patients that have significant severe constipation history in the family, mom was very constipated, grandma was very constipated, but not to the point that they had SIPO or required TPN. But then we see that these genes do run in the family. And if we started maybe doing a lot of genetic testing in severely constipated patients or patients with severe dysmotility that of intestinal failure, we would maybe see that they have this genetic mutation. So I think, these are exciting years that, where we're combining clinical and genetic this availability, but we always have to keep in mind that the clinical suspicion, it's the most important thing. And I think we're already at 10:04. If I'm mindful of everybody's time. I don't know if anybody has a question for Dr. Lambe o alguna pregunta en español o portugués. I think Pablo Lobos has a question. Do you have any experience on genetics on Ernest Danlos syndrome, vascular type, and its impact on intestinal complications?
No, I don't have much experience because we don't have too many trouble with these children. They rarely require intestinal parenteral nutrition only for a few months. But there are specialists that are looking after these children. But to be very honest, maybe we're going to have them on the ward for 2-3 months because they had a perforation or an occlusion, but not to the point of they need to be on long-term parenteral nutrition.
There's another question here from Milton Mejia. He asks, which are the principal tests to begin studying these problems, and what is the approximate cost of the test? You already said that it was 1,000, the genetic tests, but...
It's a bit less. I don't know exactly, but it would be more now, like $200, I think. It's when you do an exome that it's 1,000. Yeah, just the panel became a lot cheaper.
And if you have like the suspicion of one disease, maybe you can perform a Sankar test for that.
I don't think that's the best because with Sanger you can miss out some mutations. So in fact, the panel is actually, because of the technique, that's a bit complicated, but when you understand the technique of a chip, in fact, you miss out less mutation than when you do a Sanger. So it's not as elegant because you are going to look for several genes, but you miss out less.
Okay.
Because when there are huge dilation, you can miss it with a Sanger. And plus, when it's a really long gene, it might take a month to find something, or you might find something, but it has no pathological significance. So it's much better to do the chip.
Okay. Like a panel, as we say here. Okay, I think that we are done. It's 11:06:07 here. So Cecile,
we are on time now. It's 11:07. I think that it was an excellent explanation and a good discussion. It's a very hard situation for everybody, everywhere people are. It's very difficult, this kind of patients. So we are very thank you for this excellent presentation, as well as the good discussion. I don't know if Daniela
We just want to thank Dr. Lambe for her time and for joining us on a Saturday. Y gracias a todos por asistir también un día sábado. Muchas gracias.
Gracias por todos por la participación. Recuerdo que la próxima semana tenemos otra actividad el sábado con Lorenzo Norza, que vai nos falar sobre o uso de teduglutida. Então, contamos com todos os presentes na próxima semana também.
Y él va a comentar de la experiencia multicéntrica en Europa del uso de teduglutida en pediatría, así que están todos invitados para el próximo sábado. Bueno, muchísimas gracias, Cecile, y gracias a todos y que tengan un lindo fin de semana.
Cecile, gostaria de dizer, Cecile, would you like to say any words to end?
It was very nice to be in Latin America for a few minutes. So it's great to be able to do this. So I'm glad everybody enjoyed it, and hope you found it interesting, and very happy to do this. It's very nice.
Thank you very much.
Thanks.
Thank you.
Bye-bye.
Bye.